The Pit is the most realistic medical drama ever created, and as a viewer, that means there's a lot to learn. So today, we're breaking down episode 1 of The Pit. For those of you new to the channel, I'm Dr. Andreas Polychronis, and I'm a first-year family medicine resident. Now, since I'm currently studying for my USMLE Step 3 exam, which is the last of 3 licensing exams I have to take, I should know more than enough information to talk about all the topics we're going to see in the first episode of The Pit. So let's begin.
New intern starting today, so good luck with lucky me.
Sir, come back here.
No more needles!
Oh!
Sir!
No more needles!
Stop!
Sure you want to work today, huh?
They're gonna hurt me!
Sir, I promise nobody's going to hurt you.
Believe it or not, this does happen a lot, and this is mainly because psychiatric patients, they're usually first brought to the emergency department, and this is because it's for stabilization purposes. It might be due to a drug overdose, or they might be severely agitated, or maybe they're a threat to harm themselves or others. So they're brought to the emergency department. Once they're stabilized, they gain clearance, and then we can transport them to a psychiatric unit for proper care. But unless they gain clearance, they have to stay in the emergency department, and then we can transfer them. Another thing you have to remember is that these emergency departments, they're not really optimal for someone with a mental illness. I mean, there's nurses, doctors, there's a lot of people, there's a lot of noise. So it's a pretty threatening environment to just wake up in if you think about it. So when they do get transferred to the psychiatric units, these rooms are a lot less busy. They're plain, they're quiet. So they're pretty optimal for people going through tough times. So yeah, that's something you have to remember. It's a pretty threatening environment.
Good morning, come on over. Starting with second-year resident Dr. Melissa King, fresh from the VA.
Everyone calls me Mel. I'm so happy to be here.
I'm excited.
Trinity Santos, intern.
Victoria Giavati, MS3.
Dennis Whitaker, MS4.
Welcome to the Pit.
We got 2 traumas from the T, 5 minutes out.
Okay, copy that. Actually, this is the most important person that you're going to meet today. This is Dana. She's our charge nurse. She is the ringleader of our circus. Do what she says when she says it.
He's 100% spot on. I mean, charge nurses are super important because they dictate the workflow. I mean, they work with doctors to prioritize which patients need to be seen, and they basically communicate with all the staff, the nurses, the doctors, and all the healthcare team to make sure that everyone's on the same page. They basically assure that patients are getting taken care of.
As you can see, our house is always packed, and our department is mostly clogged up with boarders. Those are admitted patients waiting for a room upstairs, sometimes for days. Beds are a very precious commodity around here.
So already, Pitt is talking about things that no other medical show really ever talked about, and what he's bringing up now is very important. So the whole topic about boarding is basically the reason why ERs are so packed all the time. So it's not that patients are coming in and it's like so busy, it's that patients who are actually there can't leave the emergency room. And what I mean by that is, like, let's say you go to the emergency room and you're so sick that the doctors there say, you need to be admitted upstairs. Well, the problem is let's say you have to be taken upstairs and there's no rooms available. You have to sit in your ER room until that room upstairs becomes available, so you're holding up one space. Not intentionally, but I'm just saying that if upstairs is packed, you need to stay in the emergency room until a room upstairs gets clear. So in essence, let's say you have 5-6 patients all in the emergency room and they're all in the same case and they're waiting for a room upstairs. That's how you get backload, and that's how you start to get that patient pile up in the lobby. So that's what he's saying. The whole boarding situation, it's a big problem.
Hey, Doc.
And we all know Louis Cloverfield. Blood alcohol of 420 at 11 p.m.
I've been cutting back.
How is he still breathing?
That's a lethal dose for you and me. That's happy hour for Louis.
Sobered up, had 2 rounds of lorazepam.
Hold out your hands for me, Louis. Another 2 lorazepam.
On it. And a script for Librium.
It's good to see you, Louis.
It's always a pleasure, Doc.
Now, this guy's BAC, or blood alcohol concentration, is 5 times or more than 5 times the legal limit, which is 0.08%. So Dr. Robbie's right. A BAC this high would kill someone. But this patient here, you're seeing he's laughing, he's smiling, and that's because with chronic alcoholics, since they drink so frequently and so much, they build a tolerance. And you all heard this word, but what that means is that their brain and their body basically adapt to this constant high level of alcohol in their system. And these levels, even though they knock out a regular person, for them, since they're so used to it, they're able to function. But what's important to understand is that just because they're able to function and just because their body adapted to this, it doesn't mean that the alcohol is any less toxic just because they're used to it. It's just as toxic to them as it is to a regular person. Now, in regards to the shaking, now tremors like you see, those are usually the first signs of alcohol withdrawals in a chronic alcoholic. They usually occur between 4 to 6 hours from the last drink that you had and you start to shake. I saw in another video, a doctor said that these are delirium tremens. This is not delirium tremens. Delirium tremens happens in chronic alcoholics as well, but you have to wait about 2 to 4 days from the last drink, and in addition to the tremors, you'll be sweating, your heart will be pounding, and you'll have hallucinations. It's a lot worse than just the tremors. Now, in any case, to treat these tremors, Dr. Robbie prescribed 2 drugs, and they're both benzodiazepines. And benzodiazepines, they're designed to relax the patient. Now, the first drug was called lorazepam, and that's a short-acting benzodiazepine. And what that means is that short-acting drugs, they act really quickly, so it's going to get the tremors under control, but they don't have that long of a duration. So they act quick, but they're very short. So that's why Dr. Robbie, you can hear him say, hey, give me another order of lorazepam. And also, he also ordered something known as Librium, which is also known as chlordiazepoxide. That's its generic name. But in any case, chlordiazepoxide, that's also a benzodiazepine, but it's a long-acting drug. So once you stabilize it with lorazepam, you give him chlordiazepoxide, which is long-acting. So you give it once and for long-time stabilization, so you don't have to do that frequent dosing.
Incoming.
42-year-old male, Sam Wallace, blunt head with agonal respirations. Dropped down on the T-tracks. Couldn't tube him, LMA in place.
Suicide attempt?
Rescue. He's a good Samaritan. Took a spill helping a woman who fell off the track. She's right behind us.
Hey, trauma 1, go ahead. Come on.
Woman fall from T platforms, good vitals, no head injuries. Degloving injury, right lower leg with open fracture dislocation of the ankle.
So degloving injury, what that means is that the skin literally rips away from the body. An open fracture is that when a bone breaks and the bones are so sharp that it actually rips out of the skin. So unfortunately, this lady has both.
Okay, trauma 2, let's go.
What seemed like an easy morning suddenly became super hectic. Now all of a sudden he got 2 trauma cases brought in. One man, he was unconscious, and the other one was a lady and she had a severe leg injury. Now when you're an ER doctor, things can get hectic super fast. In order to navigate through the chaos, doctors, we have our own order of operations, like a math problem, that basically help us navigate the chaos. And what this order of operations does is it basically helps us prioritize what we should be looking at first when trauma patients come in. And we call this the ABCs, which basically means first check the airways, then listen to the breathing, and last check the circulation. So let's break this down. Now for the A, we want to make sure the patient has an open airway. Now we know the patient has an open airway if they're able to talk, if they're yelling, crying. Ironically, those are good signs. But if the patient has any sort of severe facial injury, any sort of facial burns, or is unconscious, we need to establish an airway, and we do that via an endotracheal intubation. And what that is that we put a tube through the mouth, into the trachea I should say, and that's an endotracheal intubation, and that establishes an open airway, and that allows air to continuously move in and out of their body. Now B, that means we have to listen for their breathing. Now even though they have an open airway and air can move in and out of their body, we need to listen to the way air is moving into their lungs, because in some cases, in like a car crash, what ends up happening is that you can break a rib and you can actually puncture one of your lungs. So that means when air comes into your body, it can enter your lungs, but it can leak out and enter your chest wall. So what ends up happening as you breathe in, you can't breathe out because air gets trapped, and what ends up happening is that there's so much pressure inside your chest, it causes your lungs to collapse and you can die. So we have to listen to your lungs to make sure you're breathing properly and all the air is going to the proper spaces. And last, the C, this stands for check the circulation. Now circulation is just a fancy word for saying just check to see the way blood's flowing through your body. We do this by looking at your blood pressure, making sure that's stable, and also we want to control any sort of major bleeding that's taking place, and just make sure you have enough blood in your body, or else we'll do a transfusion.
Pupils 4 millimeters and reactive.
Okay, that's encouraging.
What do you want for meds?
120 ketamine, 80 of rock.
AFib on a monitor.
Morson's clear.
That's a lot more blood than expected.
He's probably anticoagulated for AFib. Check his medical record, see if he's on a DOAC, standby with 4-factor PCC if there's a brain bleed.
Now this seems a lot to take in, so let's break it down. So Dr. Robbie, he looks at the patient's head and says, this patient is bleeding a lot more than expected, and to that, the other doctor goes, well, he has a history of atrial fibrillation, and then she asked the nurse to see if he's on an anticoagulant, and if he is on an anticoagulant, have PCC on standby. Let's break this down. So since this guy has atrial fibrillation, his heart beats irregularly, so as blood moves across his heart, it tends to swirl inside the chamber, specifically the atria, because it's atrial fibrillation. Now, when blood swirls through the heart, it tends to sit a little bit, and as it sits, the blood clots together. And as the heart beats again, which it beats irregularly, those clots of blood can shoot through different arteries of the body. And one of these arteries is a cerebral artery, and what ends up happening is that as these clots of blood try to move through the cerebral artery, it can block it off, and this can cause a stroke, which is a major complication of someone who has atrial fibrillation. But in order to prevent this, anyone who has AFib, we put them on an anticoagulant. An anticoagulant is a class of drug that makes it really difficult for blood to clot up. So you give to the patient, and their blood loses its ability to form clots. But the downside to this is that when we get cuts, what ends up happening is that we get a cut and the blood's ability to clot kind of patches up the cut and we stop bleeding. But if you're on an anticoagulant, you kind of lose this ability of your blood being able to clot, and you just continuously bleed like we saw over here. So when she calls out to see if he's on a DOAC, that's a class of anticoagulant known as a direct oral anticoagulant, and if he is on one, have PCC on standby, which stands for prothrombin complex concentrate. And what that does, what PCC does, is that it reverses the effects of the anticoagulant anticoagulant drug, which allows blood to form clots again. That way the guy can stop bleeding and there won't be as much blood on his head.
What's your name?
2 grams, cefazolin.
Do you speak any English?
So you heard they just called out for gentamicin and cefazolin. These are 2 antibiotics, and the reason you want to give these antibiotics is that because she had an open injury and she had exposed tissue to the environment, a lot of bacteria could enter her bloodstream, so they give her antibiotics, cefazolin and gentamicin, to act as like an umbrella, just in case, as like an insurance policy. If any bacteria got in her body, it'll die.
Airway and breathing are perfect.
As is circulation.
Good job, party people.
Subway train degloved your foot with an open fracture dislocation.
Ooh, and I thought my heels were painful. Can we please push the morphine?
No, it could cloud her mental status.
I can't do an exam like this. Push the damn morphine.
We're doing a popliteal block. Numbs the lower leg, no side effects.
So the one doctor doesn't want to give morphine because they want them mentally intact. When you give someone morphine, yeah, their pain goes away, but at the same time, it's a central nervous system depressant, so you get a little loopy, you get a little sedated, and you won't be as cooperative when it comes to asking questions as to what happened, how'd you get here, and all that, which is all pertinent questions in regards to treatment plans. So the other doctor says, do a popliteal nerve block. So in that case, you go behind the knee and you basically isolate the nerve that sends pain signals from the right lower leg, which is injured here, to the brain. So if you kind of numb that nerve, you won't feel any pain, and you won't feel any pain without compromising the mental status of the patient. So all is well.
We need to talk about your numbers.
People we've saved.
Metrics.
Our door to balloon times beat federal standards.
I'm talking about press gaining scores. Patient satisfaction.
If they're still alive, they should be satisfied.
Our goal is 36% very satisfied with their care. Your department is at 8.
What I don't understand about this whole administration scene is that hospitals generally blame the doctors for patient satisfaction, but in a setting like the emergency room, when you have to wait 6+ hours to even see a doctor, let's say you have to wait that long, no matter how good the doctor is, the patient's still going to be really upset that they had to wait that long. It doesn't matter if they come to the Pitt and their doctor's Brad Pitt and they're on the TV show, they're still going to be really mad that they had to wait that long. So yeah, it's going back to boarding, the same thing, how patients are forced to really wait in the ERs until a room clears upstairs, and then that backs up the actual lobby, and you get into this mess. So to blame the doctors on the patient satisfaction is completely wrong.
I'll stabilize the knee for the reduction. Dr. Langdon will be distracting distally before moving medially to clear the tibia.
Med student down.
Now, since I just graduated medical school, I can remember that during my surgery rotation, I had a friend that actually passed out. It was during a gastrectomy where they take out parts of the stomach, and those things, since they're robotic, they can last anywhere between like 4 to 5 hours. And he didn't pass out because of what he was watching, because you can barely see since it's like a robot. You look into this little like microscope looking machine and you do the surgery. He passed out because he was hypoglycemic. And what was crazy about this is that since the doctor was doing it through a robotic surgery, and that he's basically like laser locked in focus on the Da Vinci machine, which is, I'll show you it on the screen, he wasn't really looking around, so he didn't even notice that the patient fainted. And luckily one of the nurses came and helped him, and life goes on. Yeah.
Was this your first triathlon?
God, no.
Triathlon,
No, I do one every
muscles.
few months. Pretty short of breath.
This goes under your tongue.
I think I know what this is.
No current meds, no allergies.
We're gonna check a few
It's like
labs.
a classic case. They do this situation in a lot of questions.
Temp 98.2. Little pinprick now, okay?
Out cold.
Otis? Otis? Oh, shit. No pulse. Crash cart, lay
Crash?
flat.
CPR, CPR, CPR. You don't do the crash cart.
Let's check a rhythm.
CPR. His heart's not beating if he has no pulse.
Quick look paddles.
Don't tell me they're gonna shock him. No, what?
VTech.
Charging at 200.
Okay. This part is not realistic. I mean, they corrected it at the very end by saying it's VTAC, but if someone has no pulse, that means that their heart's not beating, so a defibrillator wouldn't do much at all. So in this situation, since his heart's not beating, is that you have to do chest compressions, right? And try to get blood beating in his heart to get it working again, because what defibrillators are for is that they shock rhythms of hearts that are beating abnormally and correct them. It's like a reset. So if your heart's not beating and has no rhythm, so there's nothing to correct, so you wouldn't do a defibrillator right off the bat, the first thing you should do is start chest compressions while someone gets the defibrillator, and you check their sinus rhythm, and you check to see the rhythm. So we found a mistake.
Charge.
Clear.
All right, it's back to normal sinus.
See,
See the
so
gurney
he had
in here?
ventricular tachycardia, and now it's the abnormal rhythm, and they shocked it, and now it's normal sinus rhythm again. So that's what a defibrillator is for. It's to shock an abnormal rhythm back into normal rhythm, sinus rhythm we call it.
Oh, groaning's good. 5 of nasal, O2, CBC, CMP, troponin, and D-dimer. What are you doing?
1 gram calcium glutamate, IV push.
We don't have the labs back.
Look at the monitor. Wide QRS and peak T waves, hyperkalemia.
get that?
Intense exercise caused muscle breakdown, rhabdomyolysis, knocked out his kidneys. Now he's not clearing potassium. I bet it's over 7.5.
Wait 2 minutes for the ice.
If you rest, we might not get him back.
Now, rhabdomyolysis is when your muscle tissue breaks down and its components leak into the bloodstream. Now, this can be due to overexertion, like we see with Otis. He's a triathlon runner. It can also be due to dehydration, and it can also be due to crush injuries, when literally your muscles get injured to a degree where they get crushed and the components get leaked into the blood. Now, when your muscle does break down, the primary concerns that we have in terms of what's leaking to your blood is first creatine kinase, which is an enzyme produced by your muscle tissue that we can actually measure. Also, myoglobin, which is a protein inside your muscles that helps store oxygen. And last, we're worried about the element potassium, which helps your muscles contract by creating an electrical gradient inside your muscles. Now, as many as you know, your kidneys are responsible for filtering out your blood. But the thing is, when the myoglobin leaks from your muscle tissue into your blood, it's actually toxic to your kidneys. So when your kidneys try to filter out the myoglobin, it causes them to fail, and therefore your kidneys stop filtering out your blood. And as a result, all the potassium that's also getting released into your bloodstream can't be filtered out, and it builds up and you become hyperkalemic. Now, when you have a high level of potassium, what that does and why it's such an emergency is that it messes up the electrical conduction system of the heart and causes it to beat sort of out of whack, and this can eventually cause death. So at this point, it's a medical emergency and you have to stabilize the cardiac membranes of the heart, and you do that by giving calcium gluconate like Dr. Robbie did. But like we just saw, Dr. Robbie, he didn't wait for the test results to come back, so we don't actually know if this patient actually has rhabdomyolysis, and this is what's going on. So let's see what happens.
Much better. Potassium is 7.7, creatinine 5.6.
High potassium and renal failure. Just what you thought.
Must be my lucky day.
Ordering 10 units of regular insulin and 25 grams of glucose.
Why insulin glucose?
Shift the potassium intracellularly.
Exactly, but the definitive treatment is
Hemodialysis. I'll call renal and get a
So luckily he was right and correctly diagnosed it with rhabdomyolysis. So you heard him say measure the potassium and creatine, and like we just learned that when your muscles break down, potassium and creatine kinase gets leaked into your blood. So when you do blood work to check these levels, you expect them to be high. Now, as we just learned, in someone who has rhabdomyolysis, the two organs that get affected are the heart. We saw that the conduction system gets all out of whack, and also the kidneys, which the myoglobin is so toxic that the kidneys' ability to filter out the blood gets affected and they start to fail. Now, since we already treated the heart, let's treat the kidneys now. Now, the first thing you do for the kidneys is that you start giving IV fluids to the patient, and this is to both dilute and help flush out the myoglobin, and by doing that, you reduce the myoglobin's toxic effect on the kidneys. And as for the hyperkalemia, the high potassium that your body can't filter out, what we do to treat this is that we want to move the potassium from the blood back into the cell, so that when we measure the potassium level in the blood, it comes back low because it's all in the cell, if that makes sense. And how we do that is that we give the patient insulin. And insulin, I'm sure you heard of it, a lot of diabetics get treated with it. It lowers a person's blood sugar level, and by lowering a person's blood sugar level, this activates the sodium-potassium pump on cells, and basically what that does is that pumps potassium from the blood into the cell. And also, in addition to the insulin, we also give glucose, because the insulin, like we said, lowers the blood sugar level, but we don't want to lower it so much that the patient becomes hypoglycemic, so we give a little glucose with it as well, which is a fancy word for sugar, to make sure the patient does not become hypoglycemic. At the very end, Dr. Robbie says that this patient needs dialysis, but that's not entirely true. What dialysis is that it's an artificial machine that filters out your blood in someone whose kidneys don't work. In this case, for rhabdomyolysis, you'd only need dialysis if you have a pre-existing condition before you had rhabdomyolysis in which you have kidney failure, or if the treatment we just talked about doesn't work, then yeah, dialysis would be the cure.
14. 89-year-old woman from a SNP. History of emphysema, CHF, MS, VFib, unresponsive to 3 shocks, 2 rounds of epi.
What is that?
Lucas chest compression system.
robotic CPR.
That CPR machine is pretty crazy, and I mean, like, believe it or not, when you do CPR, you gotta push hard. In some cases, cracked ribs can be had, but in any case, the machine that we're looking at, it's called a Lucas. All it does is a chest compression. So CPR stands for cardiopulmonary resuscitation. This is just cardio. It's not the pulmonary part of resuscitation. So you need to have someone with an air mask to allow oxygen to enter the lungs.
I got a sneaky suspicion she may be unhoused.
I'll talk to her. We can offer some help.
Thank you. I appreciate it. Ah, you're back.
Dr. Robbie suggested I might be of assistance?
Yeah, I could use the company. Victoria Giavatti, this is Chiara Alfaro. She's a department social worker, which pretty much makes her an angel.
Welcome.
For those who don't know, what social workers do at hospitals is that they help patients and their families navigate through difficult situations in regards to their health or in regards to their mental status. And the way they do that is that they connect patients with different resources like insurance help, rehab facilities, home care, and mental health support specialists. And also, they make sure that when the patient's discharged, when the patient's cleared to leave the hospital, they have a plan on how they're going to get home, and they make sure that living conditions are good at their home. So they're angels. They're angels. They're nothing short of angels.
I got a situation. 18-year-old kid brings in his dehydrated mom. Dad died during the pandemic. Mom's vomiting is self-induced for the sole purpose of getting him here after she finds his death list for classmates.
Okay. What does she want us to do?
Help him, protect him, save him.
Where is he now?
Talking to McKay. How's it going over here?
Good, good. We're just going over aftercare instructions, prescription medication, special diet for the next few days.
Dr. McKay, can you check orthostatic on Mom?
I can.
David, I wanted you to meet Kiara.
This is a very strange situation that I've never seen happen in the hospital. So basically, long story short, is a mother is brought in by her son to the emergency room, and she's pretending to be sick, and she tells the doctors while her son isn't present that she found a note in his backpack saying that he's going to go up to school. The mom didn't want to call the police because she was afraid her son's going to get into a lot of trouble, so she told Dr. Robbie when her son wasn't in the room that this is the situation, and now Dr. Robbie is talking to the social worker to see if she can do anything about it. In my opinion, it's completely unfair to try to throw the issue at the social worker and expect her to solve it. I mean, this is a life-threatening situation, and she can't be responsible to kind of talk this kid out of harming hundreds of kids at his school. Now, the best thing to do in this situation, and the only thing to do, and keep in mind the son is 18, so he's an adult, is to call the police and just tell him about the situation. As a doctor, by law, if you have any knowledge that anyone under your care has plans to hurt another person, you have to report it to the police, because if they go through with it, then you can be held for malpractice. From the perspective of the mom, I know she doesn't want her son to get in trouble with the police and all that, but since she has knowledge of these plans to hurt other people, let's say the son, God forbid, does go through to the school and hurt a lot of kids, she can be held as an accomplice because she knew about this plan to hurt the school. So she'll be just as much trouble as the son for not reporting to the police. So there you have it. That's my medical breakdown of episode 1 of The Pit, and I can't wait to do the same for episode 2. So make sure you follow along. Thank you so much, and I'll see you next time.